remit today will be to discuss left main PCI and what's the optimal antiplatelet therapy in this complex groups of patients. So, unprotected left main is common. We undertake it in around 3 to 5% of all PCI procedures in contemporary practice. It's high risk. It subtends a significant proportion of the left ventricular myocardium. And stent failure in unprotected left main is catastrophic. If you get a failure of the stent, the mortality rate is between 30 and 50%. And so it's really important for optimal PCI techniques and also the optimal choice and duration of dual antiplatelet therapy after PCI when undertaking left main. So really, my talk is going to be in two parts. First and foremost, the antiplatelet type in left main stem, and secondly, the antiplatelet duration in left main stem. So I'll cover the areas of both of these arenas. So let's talk about antiplatelet type in left main PCI. Well, a lot of our practice is guided by post hoc analyses of randomized controlled trials. There hasn't been an antiplatelet randomized controlled trial in left main specifically, so we have to go to established trials and look at their left main subgroups for information. So the first and foremost is the Triton TIMI 38 trial. This was a large ACS trial in 13,000 patients where PCI outcomes and ACS outcomes were compared between prasugrel and clopidogrel. And the left main PCI arm, left main LAD PCI arm, was around 4,000 in this group. So first and foremost, you can see from this study that prasugrel was associated with better outcomes in the LAD and left main territory compared to the other territories, and even the effect of prasugrel was much better in the LAD left main territories in the primary endpoint compared to the other vasculature. And this was particularly evident in the STEMI group, both for the primary endpoint of cardiovascular death, non-fatal MI and non-fatal stroke, and also cardiovascular death. And there was a similar benefit of prasugrel in the left main territory in STEMI. So certainly there seems to be an advantage in using prasugrel in the primary PCI setting for left main PCI, and there's an advantage in STEMI as well. And this is the primary PCI group of the Triton trial, again showing that prasugrel was associated with a 60% reduction in mortality. So in ACS case, particularly STEMI, there seems to be a benefit of using prasugrel. This is the Plato trial. So this was a randomized controlled trial comparing ticagrelor versus clopidogrel. And again, you can see that for a variety of ischemic endpoints, ticagrelor had superior outcomes compared to clopidogrel. And also, interestingly, the benefit of ticagrelor seemed to be much more pronounced in the left main subgroup. So in terms of the optimal therapy in left main and ACS, I think in line with Plato and Triton, I think prasugrel or ticagrelor should be used as first line in left main stem PCI in ACS cases where it's not contraindicated. And both the Triton and Plato trials have endpoints where patients with left main and LAD gain a much greater benefit from ticagrelor or prasugrel than in patients where PCI was undertaken elsewhere. So I think we should really consider left main as a high-risk population and really focus our ticagrelor and prasugrel in the ACS setting in these patients. So in terms of that duration, well, we often think of antiplatelet duration in terms of reducing the risk of stent thrombosis. But don't forget that particularly in ACS cases, it's not just about stent thrombosis, it's about reducing ischemic risk. And that ischemic risk may be derived from lesions elsewhere. And so we don't just manage antiplatelet duration in terms of minimising of thrombosis of the stent, because the stents, and particularly contemporary stents, will endothelialise within 3 to 6 months, whereas the ischemic risk in ACS patients extends far longer than that. And so when we're deciding how long we're undertaking antiplatelet therapy for, we should really bear that in mind, that it's not just about the stent, it's about the remote vasculature as well. So optimal duration of DACT in left main, well, this is multifactorial. I think, one of the decisions is DES versus BMS. I don't think BMS is applicable in contemporary practice. I certainly haven't used the BMS stent probably for the last 5 years or so. Stent type, now that we're moving to thinner strut stents with bioresorbable polymer, certainly the need for antiplatelet duration has shortened. But the other important point to think about is PCI indication. Obviously, PCI undertaken for an elective indication requires much shorter that duration than an ACS indication, as we've discussed. And again, we need to think about the type of left main PCI. You can have a very straightforward provisional platform, and you can also have two stents, crush technique approach, which perhaps might need longer that duration. And finally, we need to think about patient characteristics. Patients that are diabetic, elderly, and so forth, that would impact on your decision regarding optimal DAP duration in left main PCI. And finally, you need to balance ischemic versus bleeding risk in these patients. These are the guidelines for the European Society of Cardiology, and you can see that they split the duration into stable disease and acute coronary syndromes. And they further split it into bleeding risk. So in patients that are low bleeding risk, the ESC recommends 6 months DAPT with aspirin and clopidogrel, and if the patient is considered to be high ischemic risk, then the DAPT can continue up to 30 months, and we'll talk about that later. In high bleeding risk patients, in elective PCI, they suggest 3 months DAPT, but in very high risk cases, you may consider 1 month. In terms of ACS, they suggest prasugrel or ticagrelor as first line, and in low bleeding risk patients, 12 months DAPT as a class 1A indication, whereas in higher bleeding risk cases, they suggest a shortening to 6 months only. Now, one of the key factors in the antiplatelet guidelines is the use of risk scores, and they suggest the use of risk scores both to assess bleeding risk, so that will determine how short your antiplatelet duration is, as well as ischemic risk, whether you prolong your antiplatelet therapy through to 30 months. So let's look at the bleeding risk score. Well, you suggest the precise DAPT score, and this is a score made up of different weightings for hemoglobin levels, white blood cell count, age, creatinine clearance, and prior bleeding, and you get a score. And anything over 25 points is considered high bleeding risk. And the reason that they suggest the shorter duration at the greater than 25 score is because of this, because you can see shortening antiplatelet therapy does not impact on ischemic endpoints, but significantly reduces bleeding events. And so in high-risk bleeding patients, as defined by an elevated precise DAPT score of greater than 25, you shorten the antiplatelet therapy to 3 months in stable patients to 6 months in ACS patients. In terms of prolonging antiplatelet therapy in patients at high ischemic risk, we then use the DAPT score. This is a retrospective analysis of around 12,000 randomized patients, and it was validated in the 9,000 PROTECT trial cohort. And this is a score made up of different factors such as diabetes, prior myocardial infarction, hypertension, peripheral vascular disease, whether the patient is a smoker, renal failure, and stent diameter, which is very relevant in left main because obviously left mains are all going to be greater than 3 millimeters. And again, you get different points according to this score. And a high ischemic risk score is defined as greater than 2, and a low ischemic score is associated with less than 2. So in the less than 2 score, you can see that having prolonged antiplatelet therapy is associated with increased bleeding risk. So in the low ischemic score, for stable angina, you can stop at 6 months, for the ACS, stop at 12 months. In the high ischemic score, then there seems to be a great advantage in continuing antiplatelet therapy in the longer term, in that it reduces myocardial infarction or stent thrombosis beyond the 12-month point. So that's important. In the high ischemic risk score of greater than 2, you should probably continue DAP therapy for maybe 2 years, maybe 2.5 years in this cohort of patients. In terms of that, very short DAPT, I mean, we do have some data from the BioFreedom platform, from Leaders Free, and certainly there's an advantage of using the BioFreedom platform compared to bare metal stents. But I have concerns about this data because it may not be applicable to left main patients, very few left main patients in this trial, and it doesn't really inform whether we should use shortened DAPT is safe. I mean, there's no control group where they've used 6 months or 12 months DAPT. So I personally wouldn't use a 1 month DAPT in left main because of the potential catastrophic results. And again, in the Leaders Free, left main was very rare, 3%. There is going to be one randomised controlled trial, the ideal left main trial, and that's in progress, randomising patients to dual antiplatelet therapy for every 4 months. That's ongoing. So in conclusion, in ACS cases, patients sustain a much greater benefit in left main using prasugrel or ticagrelor. That duration is dependent on a number of factors. Duration of 6 months for elective cases, 12 months for ACS cases, might be longer for high ischemic risk patients or shorter for high bleeding risk patients. Thank you.